A very good afternoon, everyone, and once again, welcome you all after the post-lunch session. So, this is a post-lunch session, and I have been requested by the organizer to finish my talk in 20-25 minutes, although I've been given allotted 30 minutes time. But I will try to finish in next 20-25 minutes. And this is a session, I hope you will find it interesting because I'm going to talk about some very important X-ray findings which helps us in making a diagnosis in various pediatric surgical conditions. So X-ray is a very important tool, and it is important because most of the time, especially whenever you are suspecting, whenever there is acute abdomen, most of the time you are able to make a diagnosis just by reading X-ray, abdominal X-rays. It's very accessible and non-invasive tool, and the most important thing is once your interpretation is good, then it helps you in deciding the next imaging modality. And we all understand that there is a very limited role of advanced imaging, especially in neonatal and the pediatric age group. So X-ray can give you a lot of good informations, will confirm your diagnosis, and most important that it also helps in minimizing the radiation dose to the child, which is what we want in our pediatric patients. So X-ray is crucial, very important because it not only gives you early diagnosis, you can intervene early, especially if it is a surgical emergency, and also because of this, it will help in improving the outcome. So what is required is a good structured and the orderly approach. Very important is, first you have to confirm the identity. When you are reading an X-ray, you should always confirm the identity of the patient. Confirm from the name, ID, date and the time. And you should have the previous X-rays also available with you so that you can have a good comparison with the previous X-ray and the fresh X-ray. One should have a fair idea about the normal anatomy, what we see in the X-ray, what normal anatomy look like, and you should be able to pick up any abnormal finding, any pathological finding on the X-ray. And then you can compare it clinically with the symptoms of the child, and then you should be able to formulate a differential diagnosis. So a very simple algorithm is that these are the 4 things you should always look for whenever you're reading abdominal X-rays. Number 1 is the gas pattern. Number 2, how the solid organs they are looking like. Number 3 is the osseous and the soft tissue shadows. And number 4 is the tubes and lines, because most of these patients they are in critical care unit and they are with the tubes and the lines. So you should always try to look for all these 4 important things whenever you are interpreting an abdominal X-ray. So basically, you will when you see X-ray, you will be seeing 3 densities. So the gray density represents soft tissue, black air, and the white density is because of bone calcifications, tubes, and the lines. So these are 3 important densities you should always keep in mind when you are interpreting the abdominal X-ray. Types of views depends on your requirement, what you want to see depending on the condition. You can order a supine film, erect film, prone, cross-table lateral film, decubitus film, or sometimes you can use air as a contrast media and can repeat X-ray. As a surgeon, we usually prefer to have erect film because the erect film gives us a very good idea about the intestinal obstructions. It gives idea about the free air. So if you want to see airflow levels, it's always better to have an erect film. Prone cross-table lateral view is usually performed in the patients with anorectal malformations. Now we don't prefer doing invertograms, we prefer doing cross-table lateral views. If the child is critical, cannot be positioned in the erect, then you can always take a decubitus film to see the free air under the abdominal wall. So why erect film? Because air being lighter, it always goes up, and then you will be able to see the multiple air fluid levels. And you can then now judge that what's the status of the gas in the intestines. Erect film always give us a good idea about the free air inside the abdominal cavity, so that you can make a diagnosis of pneumoperitoneum. You will get the relevance of the supine erect film by looking at this X-ray. Like this child who has been taken a supine film, and if you see very closely, the liver shadow is looking very abnormal, and that's something hyperrecency in front of the liver shadow. And basically this child was having a pneumoperitoneum, and a supine film was taken, so air, instead of going below the diaphragm, it has come below the anterior abdominal wall, and this is how you see a hyperrecency in front of the liver. That is called as a hyperrecent liver sign. So these important findings can be missed if you are not taking an erect film. So if child is critical and you are suspecting pneumoperitoneum, you can always take a lateral decubitus film, and then a free air can be seen below the abdominal wall, and then you can make your diagnosis of pneumoperitoneum. Again, this is a supine film which is being taken. This child was having intestinal obstruction. Although this supine film is giving a fair idea that the intestines are not looking normal, these are the dilated loops of the intestines, they are thickened loops of the intestines, but yes, you are missing the air-filled levels and the transition zone. So a normal skygram, you should have a very clear picture in your mind that how the normal skygram should look like. There will be a liver shadow on the right side, there will be a snake shadow on the left side, there will be a stomach bubble seen in the left upper quadrant, and then a uniform gas pattern seen all over the abdomen. Although this gas pattern can be very variable, and even a normal pattern can be very variable, but still you should have a good idea that how a normal gas pattern should look like when you are seeing a normal skygram of the abdomen. Now, when you assess the bowel gas pattern, then you should look for any focal distension, any abnormal distribution, any high versus low obstruction, because when there is a high obstruction, then you will just see gas in the upper half of the abdomen, paucity or too little of the gas, and the airflow levels because of the obstruction. Now, if you see this X-ray, this is a neonatal X-ray, and this is a very classical X-ray of the newborn with a uniform distribution of the gas pattern, which is being described as a honeycomb pattern with the gas seen also in the rectum area, and this is something in normal gas pattern which you see in the abdominal X-ray. Now, gas should always be seen within the intestines. It should not be seen extraluminally. So, whenever there is an extraluminal gas, the diagnosis can be either in pneumoperitoneum, pneumatosis, or sometimes you can see gas even in the portal vein. What is focal dilatation? As you can see here, this child who is 1 month old presented with a projectile vomiting, and you can see there is a hugely distended stomach here with a hyperspedistasis. So probably there was something obstruction at the level of pylorus. That's why there is a gas getting accumulated inside the stomach and causing the gastric distension. Now, it is very important to differentiate between intestinal obstruction versus ileus. Why? Because true intestinal obstruction needs a surgical correction, but not the paralytic ileus, which we see in the patients with either gastroenteritis or sepsis. So, if you see this X-ray, here you can see there's some dilated bowel loops are seen with few air-filled levels also seen, but they are very small air-filled levels, and also there is some gas in the rectum. Right? If you see this X-ray, there are multiple large air-filled levels seen with sort of a step-ladder pattern with absence of gas in the pelvis. So this is how the true obstruction looks like, with a large air-filled levels in a step-ladder pattern, absence gas in the pelvis, which suggests there's some cutoff in the small intestine. While in an ileus picture, you will always get a small air-filled levels, few dilated bowel loops, and also sometimes you can get gas in the colon and rectum. Now, this is looking very unusual, correct? So that doesn't look like an intraluminal gas. And if you see very closely, this is a gas in the form of linear shadows and the streaks, which is the intramural gas. So here there is a gas not inside the lumen, but it is in the wall of the intestine, which is a condition which can be very critical for the child. That is the pneumatosis intestinalis, which suggests that there is an intestinal ischemia and this child will require urgent intervention. This is an X-ray of the similar picture, same child, and when we saw this X-ray retrospectively, that there was also a gas seen in the form of branching pattern in the over the right liver. So this was a gas present in the portal vein. So these are the important findings which should never be missed, because if you delay your diagnosis, the child can become more critical. Now, after gas, second thing we should look for is the osseous and the soft tissue shadows. So like this, if you see in this X-ray, there is a large grey soft tissue shadow seen here. The bowel loops are displaced on the one side, and if you see very closely, there's some calcifications also seen in the left upper abdomen. So there's a hugely distended abdomen with a large soft tissue shadow, and this child was having a large pelvic cystic teratoma which was arising from the pelvis and had calcification also. Now, third thing which you should always look for is the tubes and the lines, because most of these patients, they are in the intensive care units. So you should always look the position of the tubes. You can see here, there's a coiled tube here. The umbilical catheter, which should be ideally somewhere here at the level of diaphragm, it has gone up. So the positioning of the lines, you can always confirm by reading a good X-ray. This child presented with a pneumoperitoneum, and we never suspected that there could be a stomach perforation, but retrospectively when we saw the position of the nasogastric tube was going in the pelvis. So the tube has perforated the stomach and it has gone down till the pelvis. So this was a stomach perforation caused by the nasogastric tube. So now, before moving on to the next part where I will be discussing some common classical findings of the abdominal X-rays which we come across in the neonatal obstructions, I will just want to memorize the common conditions of intestinal obstruction in the newborn period. So gastric outlet obstruction, the cause is pylotic atresia. Duodenal obstruction, cause is duodenal atresia, malrotation. Jejunal-ileal obstruction is mainly because of the atresias in the jejunum and the ileum, meconium ileus, and sometimes total colonic aganglionosis. And the colonic obstruction can be because of Hirschsprung disease, anorectal malformation, and the colonic atresia. So these are the common differential diagnoses which should always be in your mind whenever you are reading an abdominal X-ray. Now, this is a newborn period. He is born with a bilious vomitings, bilious aspirates, and if you see, there is not much abdominal distension, almost gasless abdomen except for the two small air fluid levels. So this is something which is very classical, called as a double bubble sign. Now, this is an X-ray which is taken immediately after the newborn was born. So when the child is born, the gas will take some time to traverse and reach till the rectum. So it takes almost 2 hours, 1 to 2 hours to reach the duodenum, around 7 to 8 hours to reach the small intestine, and around 24 hours to reach the distal part of the large intestine. So if you take X-ray immediately, then you might miss you might miss the gas pattern in the newborn patient. So although the bubbles are not looking very classical, so what you can do is, just to confirm your diagnosis, you can always inject some more air. So when you inject some more air, then you will have a very classical picture of double bubble sign which is seen in the duodenal obstruction, that is duodenal atresia. And this is a duodenal atresia and child required a duodenostomy. Now, almost similar picture, there is a bilious vomiting, but there is some mild upper abdominal distension. And here, instead of one bubble, there are 1, 2, 3 bubbles. So this is again very classical. There is no gas dystally, finding suggestive of jejunal atresia. That's a triple bubble sign. So that's a jejunal atresia which was operated. Now, sometimes you can get such kind of picture which can be very confusing, because here what you're seeing is there's a gross abdominal distension, the multiple dilated bowel loops with also a few air fluid levels seen. There's no gas in the pelvis. So when you get such kind of picture, then you will have a multiple diagnosis, differential diagnosis. Number one, it can be ileal atresia because there is some distal small bowel obstruction. It can be a Hirschsprung disease, total colonic aganglionosis. It can be some meconium plug which is causing obstruction in meconium ileus, and also sometimes you can get such kind of picture in necrotizing enterocolitis. So this kind of X-ray picture can be challenging and it might be difficult for you to make a diagnosis. So for that you will have to correlate clinically, and you might have to do some additional studies to confirm your diagnosis. So this child had a ileal atresia for which he was operated. Here, what you're seeing is a very large air fluid level. So this is again a very classical picture which you see in colonic atresias and sometimes also in the pouch colon. So there is a large intestine with a large air fluid level, findings suggestive of colonic atresia. So these are the different kinds of atresias which we usually come across, and you should always keep in your mind the very classical picture of these X-rays, that is double bubble, triple bubble, multiple air fluid levels and a single large air fluid level seen in the colonic atresias. Now here there is a slightly different presentation. Till now we have seen that the child presenting with the bilious vomitings have a almost gasless abdomen. But here what you're seeing is that there is a double bubble sign, but also there is some gas. Although there is a paucity of the gas, but there is some patchy gas pattern seen distally. So such kind of presentation goes usually in favor of intestinal malrotation. And this is a very important finding which should never be missed, because intestinal malrotation should be considered as a true surgical emergency, because child can land up in the intestinal volvulus and should be operated as soon as possible. Also, such kind of picture you can get in patients with duodenal web with perforation. So that's how malrotation looks like when instead of DJ junction lying on the left side, it lies on the right side, and then it leads to the duodenal obstruction and intestinal volvulus. Now, if you want to confirm your diagnosis of intestinal malrotation, you can always do upper GI study, where you can see that the DJ junction, instead of coming on the left side of the spine, is lying on the right side. So the advantage of the additional studies is that you will further confirm your diagnosis and then you can proceed. Now, child had an intestinal volvulus here, so that's a patient with a malrotation with intestinal midgut volvulus. This is almost gasless abdomen secondary to the intestinal ischemia because of the intestinal malrotation. Now, mostly these cases of obstruction which you see in neonatal practice, they will not have abdominal distension right from the day one, correct? So there will be always a progressively increasing abdominal distension. Now this is a child who has a progressively increasing abdominal distension, and what you see in this X-ray is a very similar picture which I showed before, that there are multiple dilated bowel loops here. There is no gas in the pelvis, correct? So whenever you see a neonatal abdominal X-ray, it is not possible to differentiate whether it is a small intestine or it's a large intestine. So in newborn babies, you cannot differentiate the large and the small intestine, and this kind of picture can be very confusing because you have a multiple differential diagnosis for such kind of findings. So what you can do is that you can always order for a contrast studies. So next step would be to perform a contrast studies. So here, this is a contrast enema study done with the help of the gastrography, and what you can see here is this part of the colon is collapsed, correct? This part of the colon is a small caliber, and the dilatation is starting from this part of the colon. So the obstruction is not at the level of small intestine, but the obstruction is at the level of large intestine, somewhere near the splenic flexure, and these are the findings which are highly suggestive of Hirschsprung disease with a transition zone somewhere at the descending colon. So if your diagnosis is, if you're not sure about the diagnosis, you can take the help of the additional contrast studies. Similarly here, the same picture, we have done the gastrographic enema, the transition zone is somewhere in the mid-sigmoid area, suggestive of Hirschsprung's disease. Now this is what we call as a microcolon. When the colon is unused in patients with a distal small intestinal obstruction, then this is a very small caliber colon which you see, and that confirms that there is some problem in the terminal ileum. Now, as I said, the distension in these babies is usually not seen at the time of the birth, and the distension is progressive. But there can be scenarios where the distension can be present right from the birth. So this child who has a distension right from the birth, bilious aspirates, child has not passed the meconium, antenatal scan has a finding of echogenic and the dilated bowel loop. And if you see the abdominal X-ray here, there is a distended abdomen, large distended bowel loops, but no air-filled levels. This is very important finding here. There is no air-filled levels. Some soap bubble appearance on the right iliac fossa, and this is something which is very classical for meconium plugs. So this is a child was having a meconium ileus where there is no air-filled level because meconium is very viscid and tenacious. It will not form the air-filled levels. And then if you want to confirm your diagnosis, you can always proceed with the gastrographin enemas, because gastrographin enemas being a hyperosmolar agent, it will help in diluting the thickened viscid meconium. Child might pass meconium plugs and the obstruction might get relieved. So these are the very important findings you should always look for in the X-ray, so that you can confirm your diagnosis and then can proceed with the next investigation, and your investigation like gastrographin enemas can be therapeutic in such kind of cases. Sometimes you can see calcifications because of the antenatal perforations. So this child had a meconium peritonitis with antenatal perforation and calcification. Now there are 4 conditions where you will see the abdominal distension right from the birth. First is meconium ileus, which I have already described. Second is meconium peritonitis or ascites, any abdominal lump, and the ascites. So obstruction, you will never see distension right from the birth. But in these 4 conditions, you will always have a distension right from the day 0. Now coming to the next diagnosis, that I have already shown this. This is a pneumoperitoneum. We have done a lateral decubitus film, and there is a free air below the lateral abdominal wall, anterior abdominal wall, and finding is suggestive of pneumoperitoneum. This again, there is a extraluminal hair here, and this child who was around 3 months old presented with severe gastroenteritis with a septic shock, and when we did the X-ray, there was a air seen in the intramural part of the intestine, and when we did the CT scan to confirm this diagnosis, you can see here that the air is lying in the intramural part, with the air also seen within the liver in the portal vein. So again, this is a very grave situation, and the child required excision of the ischemic intestine. This is very classical finding of gas under diaphragm, gas seen on both below both the domes of the diaphragm in the patients with CA stomach. In the patients with stomach perforation. Now, whenever you are seeing abdomen, you should always look for the chest X-ray also. So this child was having a tracheoesophageal fistula, and you can see here there is a coiled feeding tube which is seen in the upper esophageal pouch. One should also look for the gas pattern in the abdomen, because in a child with esophageal atresia, if there is a gasless abdomen, it is suggestive of pure esophageal atresia. And if there is a fistulous communication, you will always see the gas in the abdomen. So this is how we differentiate between the type A and type C esophageal atresia by looking at the abdominal X-rays. Now this X-ray, as I said, when you are seeing the X-ray, you should always also look for the gas you should also look for the chest X-ray also at the same time. Although there is a gasless abdomen here, but you can see there is a round opacities in the left hemithorax. So all of the intestines, instead of being lying in the abdomen, they had gone into the left hemithorax because of the large diaphragmatic defect, and this is a classical finding which we see in the patients with a congenital diaphragmatic hernia. So there is a gasless abdomen. It may not be any cause because of the ascites or volvulus, but it can also because of the congenital diaphragmatic hernia, where intestine loops have herniated in the left hemithorax. So I would like to conclude now, and just to summarize, this X-ray abdomen is a very basic but powerful tool in diagnosing especially acute pediatric and the neonatal abdominal conditions. One should have a very systemic and the orderly approach so that you should not be missing any subtle findings. And one should know how to interpret the abdominal gas pattern whenever you're reading an X-ray. And whenever you are in doubt and you can always order for an additional contrast studies, which will be more informative and will help you in confirming the diagnosis. Thank you so much.
Excellent presentation. Prashant.
Thank you.
Your choice of films and images are also been very wonderful. If this much radiology everybody was to learn, I don't think there is a full. If this much radiology everybody was to learn, I don't think there is a job for us to do anything much more here. Anywhere in the pediatric age group, I think we should be very conscious of the radiation that we give. So we should be, most of the time, in fact, 95% of the time, the X-ray, as he said, abdominal rectal supine in case required decubitus, and a chest X-ray, and added with it an ultrasound should provide you most of the time the diagnosis that you are looking at or the patient, the child is presenting with. So going for a higher studies, though nowadays is becoming a little bit of a craze, I think we should be very conscious of amount of radiation exposure we'll be giving it to the child at this little small age. Because in the lifespan of around 70 years, if you were to talk about the amount of radiation exposure that we will ultimately be giving to that individual will be very high. So one should be very conscious of that particular thing. And then most of the time you don't need it.
Correct.
In fact, it is just done to safeguard yourself. The CT that you showed in which there was air in the portal vein, I don't think we really need it, but I don't think maybe nowadays the parents are also so aggressive and so demanding that they may force you. But I think if we persist with this knowledge and we have a good understanding of the gas pattern, the perforation, the bowel loop displacements and everything, I think that should be good. Excellent presentation.
Thank you.
Very well. Very well.
आज की तारीख में कोई पेन एक्सरे की बात करता है तो अच्छा. The fact is, and Dr. Prem has mentioned this, oftentimes a lot of our X-ray imaging and other modalities are knee jerks. Something wrong in the tongue, ultrasound to cry.
Correct.
I have never understood why intestinal obstruction should be or would be diagnosed by ultrasounds. As just a quick query around the house, one CT abdomen gives how much radiation to a child? 100. How many X-rays?
1,000. 1,000. 1,000.
So average would be about 400. Usually about, the better the CT machine is less, but most of our CT machines will give upwards of 400. So every time you're asking for a CT scan, have that figure in mind. And I think you'll do a lot of good knowledge.
Thank you, Prashant, for your excellent presentation. I just want to add one or two things. One is, in plain X-ray, you cannot ignore foreign body, because a lot of things you have to foreign body. Even nowadays, the Chinese button batteries, magnets, and all are diagnosed with an X-ray. You can confirm only in X-ray. So that needs more in diagnosis rather than follow-up also. And whenever we are dealing with acute abdomen in newborn, I always teach my residents to always correlate with the antenatal ultrasound of the mother. That gives you a lot of clue. Whenever in doubt, just a little bit of correlation with that, you will find your diagnosis. And one personal experience what we are doing right now, I'm telling you, we are dealing a lot of trauma cases. Because in our trauma center, every day we are getting now and then is a handlebar injury, the pediatric patient. So out of them, around 10% are the duodenal rupture. So it's very difficult if you do not have a clinical acumen and a good X-ray abdomen. Initially, you don't need a CT. And if you are in doubt, just put a few ml of air. You will find a streaks of air on the
retroperitoneal.
It's a typical history of handlebar injury and tender abdomen. You can diagnose abdomen. So, as we say that the clinical examination, there is no substitution of clinical examination. So same plain X-ray, there is no substitution till now in my opinion. Thank you very much.
Thank you.
Sir, with due respect, as a surgeon, you only covered that. X-ray plain abdomen is very good tool for diagnosing constipation. Constipation as well. Plain you can. I mean,
Our finger is enough, sir.
Actually, per rectal examination is not a choice now, absolutely to diagnose constipation. It's not a choice for it. The brain can answer that
Yes,
for
yes, sir.
plain X-ray abdomen.
Yeah,
or
it does.
constipated, direct
It
position.
is a good indication.
And no ultrasound required even now.
No.
And what about renal calculite and such calculus?
Yes, so yes, of course, yeah. For radio opaque shadows, as I said, then if there's a radio opaque calculus, then you can always easily pick up on X-ray. Although CT is considered to be the most sensitive,